Our next speaker is Dr. Alika Maunakea, who will be speaking about the topic on the Maui Wildfire Exposure Study. Dr. Alika Maunakea is a native Hawaiian professor at the John A. Burns School of Medicine, University of Hawaii, Manoa. Dr. Maunakea co-founded and co-directed the Maui Wildfire Exposure Study, the most comprehensive study aimed at understanding and reducing the health and social impacts experienced by the Maui, Hawaii community following the wildfires in August 2023. Please join me in welcome.
Thank you for that nice introduction. Oh my God, Cole. It's awesome to be here. Thank you so much for inviting me to join you all for this, to share some of our work, Velma. And Jack, thank you so much. It's been awesome to just listen to everyone's amazing work in our community and how that can be done and improved, and hopefully encourage the next generation as well to come and join our team and help to get that out in a long-term way. So today I'll have the privilege of introducing you to our study, one of many community-based research projects that we are working on to address and understand health disparities in our community. We call it the Maui Wildfire Exposure Study, or Maui West. This is in collaboration, multidisciplinary collaboration with various groups within the university as well as outside the university, including Dr. Ruben Warris, who's in the room, who's leader in one of the co-leads on the study, as well as with UHERO and the College of Social Sciences, as well as other members the scientific and lay community that's helping to partner with this project to help us understand some of the emerging acute impacts of the fires, as well as the long-term impacts that might manifest in the years to come. So I'm just going to share a little bit about what we do in general. I'm not going to dwell too much, but we've used community academic partnerships in the past and many different projects on trying to understand and address health disparities in our community. I'm glad that Mia was here today too. She's also our partner in Pacific Alliance Against COVID-19 that we established years ago to work with schools as well as FQHCs to instill programming, education, as well as critical logistical and technical support to address some of the challenges for COVID testing and vaccine uptake and all of that. As well as working with other organizations, UHERO, to establish a long-term cohort to understand some of the health and social conditions in our population throughout the state, and then develop other programs looking at diabetes risk factors and other health disparities to better address some of these issues, but again, using this community-based approach. What we've learned throughout all of our projects, I think, and what we've been able to achieve, I'm really proud of, is that the research can be done in a way that actually impacts individuals' livelihoods while the research is being done. So it doesn't have to take 20 or 30 years for the results to have an impact on the community. It can be done now. So the way that we do that is we use a blended approach that incorporates some of the research components. Again, it's a mixed methods approach where we have heavy metrics as well as qualitative data, and integrate that with multidisciplinary frameworks. And then we also provide health education or health service to communities that, of course, are affected with health disparities at the same time. So this Maui West study is just an example of how that's achieved and how that's affecting individuals' livelihoods on the ground, as well as what we're trying to understand how that's impacting the community over time in general. So again, as we're approaching the 1-year mark post-wildfires in a few days, many of you guys already know about what had happened last August on Maui. Wildfires really damaged and pretty much decimated Lahaina and parts of Hula, and that's shown on this map here where the extent of the fires happened on Maui during that time. Of course, it affected a broad community, and those communities reflect communities on Oahu as well. We're very multi-ethnic and culturally diverse. So this is just going to give you a breakdown of some of the demographics in Lahaina. We were, of course, taken aback by the event, and learning from lessons learned from previous disasters, such as the 9/11 tragedies. Where, we realized that the long-term effects of exposures to these disasters are just manifesting in those communities, and we're hoping that that doesn't repeat on Maui. So we really did rally together to try to pull our resources and our ideas, and with community partners to address some of those short-term needs that were emerging, as well as address some of the long-term issues that could happen. And this is really a grassroots initiative. I wanted to introduce that my great grandmother, who I was born and raised with in Honolulu, in a homestead community. She was a Hawaiian healer as well as hakumele. She was born and raised herself on Maui in Kula, and wrote the song, if you guys are familiar, Aloha. So, part of this story is really about her wanting us to be there, present in our community, and helping as best we can, not only in the short run, but of course in the long term. The other aspect of this is that we're health disparities researchers, but I think, and not disaster researchers specifically. We've learned a lot from previous disasters, but I think the challenge and the punchline that I'll end with in the talk, really, I'll just say up front, is that in order to build resilience against disasters like this, now, before others happen, not just for us, but in other parts of the country, part of that equation will be is addressing and meeting and covering the gaps in health disparities. So I think that's what we've learned in our work with Maui. I did want to also bring up family, because that was really an important key element, because we did have family members affected by the tragedy, and we reached out to them, and it was actually that starting point that helped us to navigate how we would address some of the emerging needs, learn about them, sit down face-to-face, and understand who are the partners that we can work with on the ground that have been serving community in that capacity, and then how we can really serve them in terms of the research and how that can be incorporated in a good way. And so we partnered with many community organizations that were already on the ground serving community in different ways, especially with the resource hubs that was set up. We were invited by some of these groups to come over and just meet and greet and talk story, and try to understand what we can provide to them, how the research communities shape some of the emerging issues that they're dealing with, as well as meeting some of the needs. And so with that, we asked them to be part of our community advisory board that we've assembled, and here are some of the examples of the many groups that we have represented there that could help shape some of the study design, incorporate new metrics that we hadn't considered that they saw that was a need for the community. And then, of course, we brought in our experts as scientists to the board, to a scientific advisory board that were very familiar and engaged in disaster research, air pollution research, exposures research, and that kind of understanding to help us. Some of that, for example, included partners in the World Trade Center clinics that are serving the affected individuals from the 9/11 attacks. And so we've learned a lot from them as well. Again, this is a multidisciplinary team that we built with initial funding from Hawaii Community Foundation, and then later on Kaiser Permanente, as well as finally NIH. And we work with other partners that provide some services to our community, language accessibility and other support to address some of the needs in the study, but also, of course, the ongoing needs in the community. So our study goals and timeline is just depicted in this graphic here. Our first year was really to rally together to establish a cohort of 1,000 adults that's impacted by the fires to better understand and address some of the short and emerging long-term health outcomes. So in the first year, we assembled a team to help us identify what kinds of metrics we would collect from participants, and this is just some of the data elements. We intend to study participants over the course of time. We are funded for 5 years to look at some of the short and midterm endpoints, as well as longer term endpoints that we're considering, hopefully with continued support beyond 10 years, because we know some of these outcomes, such as cancer, would emerge at that later time. So we want to understand how we can intervene earlier to see if those individuals might be at risk for those conditions, so that we can prevent that from happening. And of course, reduce the mortalities as a result from exposures to the fires. Okay, so we finally, when we received Hawaii Community Foundation support, that was our initial funding agency we worked with, we were able to gather a team and have them trained and well supplied and resourced, and we work with our community partners on the ground in hotels, ballrooms, in public places, churches, as well as community centers to set up a pop-up to engage community members to participate in the study. We started data gathering on January 26th, which was the earliest we could get that kind of support set up, and started collecting and started recruitment. And these are just some of the elements, again, the data elements that we collected from participants in the study. They include mostly by questionnaire demographics, so food security, housing security, exposures, resiliency factors, social support, certain behaviors and health, perceived trust, and a bunch of other metrics. We also included biospecimens. So I'm an epigeneticist by training. My goal is really to understand some of the biological underpinnings of health disparities, to identify how early that might emerge before clinical manifestations to enable prevention. So we collect biospecimens to study that. We collected urine, as well as saliva, blood, and buccal cell swabs to look at different pathways such as stress response, inflammation, and environmental toxins that individuals, survivors might be exposed to. And we also provide a health exam or health screening on site, and that includes pretty comprehensive assessment of lung health using spirometry readings, cardiovascular health, metabolic health, as well as mental health from the surveys. And then links to their EMR data to look at cancer risk before, and as well as emerging risks afterwards during the follow-up. To date, we've enrolled more than 800 participants in the study, and that actually was over the course of 16 recruitment days, and we're so proud of how much our community partners worked together to rally that so quickly. And actually what was really surprising was how diverse our community was in representing the diverse individuals that were impacted by the fire. So here's just a pie chart of the distribution and proportion of individuals by ethnic group. And you'll see pretty great representation, high recruitment in this cohort of Filipinos, Hispanic and Latino populations, Native Hawaiians and Pacific Islanders, and whites, as well as others. There's also diverse by age groups. A majority of the individuals in the initial cohort are about 35 to 64 years old. That's about 64%. But we also get pretty good representation, about 20% each of the younger and older groups. Almost equal proportion also by gender. You can see males a little lower, 43% compared to females at 57%. And that's what we see in most cohort studies. There's an enrichment of female participants in these types of studies, but still good representation. In addition to sort of the ethnic representation and age, we also see a pretty broad residential representation of the community impacted by the fires. And this is represented by little black dots here, which are the geocoded residential addresses of where people were during the time of the fires. And over Lahaina on the left and in Kula on the right. So we are looking at both areas. And then you can see how dispersed the residential addresses are in those neighborhoods in Lahaina and as well as Kula, and then how where the fires were during that time. And this is just an example of some of the pop-up settings and what the logistics look like and what the actual screenings stations look like at these mostly community sites. And we set up in a room where we have a check-in, check-out station. Participants know about the study. They can sign up online and come in, or we take a lot of walk-ins and just word of mouth. People come into the study to learn more about it. Once they learn more about it, they provide that informed consent. They fill out the questionnaire either by paper or usually by a tablet. They prefer electronic questionnaire, which we welcome. We also have community partners that help us with any accessibility issues, language issues in particular, to help with facilitating some of those questionnaires. And then they come into the room where we then have them deliver their sample of urine that's collected on the spot. So there's a bathroom that they go to. They get this little baggie of all the supplies that they need to go through the station, so then they didn't know which stations they've been to. So they drop off the urine samples as well as we send them down to phlebotomy, get a blood draw. We also provide an iStat. So this is measuring some certain blood chemistries on the spot. It takes a few minutes, so we get those results to them right away. In some instances, we're able to work with the Department of Health that provides lead testing, and on the side, if any individuals want to have that, that's an option. We collect saliva and buccal cell swabs in the other stations and then send them over to get their height and weight and blood pressure measured. And then finally, the spirometry, where we do the lung health assessments. And then we actually have the results for some of these major metrics already available to them and record them. And then we have a consultation, one-on-one consultation with them about what those results mean, where they can go if they don't have extra, insurance or other support. So we provide that one-on-one. That's usually done by me or someone on the team, nurse practitioners, as well as medical students as well, and some of our physicians working in the medical school that are helping to volunteer and provide that service as well. And that's been really helpful. for many things. This is just an example of the participant results sheet that we give them and that they pass around. They had a hard copy in paper of this, but they also get an electronic version. But we record information like blood pressure and where you are on the chart, spirometry readings, that's one of the lung health outcomes, as well as some of the blood chemistry work as well, some of the things that we follow, especially for glucose levels, creatinine levels, and lactate. And we provide that information. Again, this is in the form of a consultation, and there's other resources that we refer them to during that consultation. And then we also provide them a link with their personalized data portal. So this is another way we disseminate information. So again, we collect not just the paper, but they also get access, an electronic version of the information that we collected, and they get secure access to their own personal data portal of the study. And this is just representation of that in the top. But then when we get more information, such as what we were getting from the samples, and I'll explain a little bit about that, we post those results and then we let them know that it's been updated so they can check back what that is. And that's how we keep them engaged in the cohort, is through this individual dashboard that we provide for free. In addition to that, we also have an aggregated data set from the cohort itself, so they can see where they are in terms of the cohort with some of the metrics, and that's also provided, and that's a public facing dashboard. And so you guys can also take a look at that on the Your Hero website if you're interested where we are in there. Of course, a lot of this data we're still collecting, but we're updating as we go. Again, I'll point you to the mauiwest.info link, and you can learn more about the study as well as the dashboards if you might be interested in. We just reported in May, our 6 month after the tragedy, where we were with that cohort and some of the data that was coming out. I'll just briefly touch on some of that today, and if you guys have any questions, I appreciate the feedback. So some of the emerging trends that we found so far with the study is that, of course, there's mental and physical health issues, access to care, housing, and job and food insecurity. And I'll go and touch a little bit on some of the data that was revealing. We were fortunate enough to have a small cohort of participants from a previous study before the fires happened on Maui. So we have some baseline for some of these data elements to compare that with our cohort that's in the Maui West. So that's going to be referred to as the all of Maui labeling here. And that's that small cohort that's before the fires. And then we can compare that to the Maui West cohort, those that we enrolled that's after the survivors from the fires. And so you can see for metrics like depression, self-esteem, suicidal ideation, that's all up in comparison to the all of Maui, so the previous cohort unrelated to the fires. So in general, we did see alarming rates of mental health issues that was previously reported by others as well. 52% of the participants showed depressive symptoms, 19 reported low self-esteem, 30% had moderate to severe anxiety, and about 4% had considered suicide in the past month. So, this obviously pretty alarming. This was the data that was collected at the time. Nearly half of the participants also reported worsened physical health as a result of the fires, particularly those that also reported higher exposure to the fires, the ash and debris and smoke. And this is what it broke down to in terms of the, oops, sorry about that. Don't know why that's happening. This is how the data broke down in terms of the more common symptoms that people were reporting. Respiratory issues was among the most common: coughing, wheezing, difficulty breathing. Eye and skin irritation, fatigue or weakness, the most common symptoms again. That's reported, and it's broken down based on the frequency. We also saw that the self-reported exposures, the degree of self-reported exposures, were associated with the symptoms that they're expressing. So individuals that frequently, that expressed to have been exposed more frequently than others to the debris and the ash and the smoke tended to have more symptoms. And that's in the purple line, as you can see. And then some of the symptoms and how they break down. Cardiopulmonary risk, when we did the assessments and the health screenings, 74% of participants faced a higher risk for cardiovascular disease due to elevated high blood pressure and at the pre-hypertension level. And you can see that on the top pie chart. Up to 60% may suffer from poor lung health from the spirometry measures that we did on the baseline readouts, and about 40% with mild to severe lung obstruction. And actually many of the participants that complained about having respiratory issues went out to use this data with their PCP to get treatment. So that was really nice to see. What we also learned while we were doing the health screening was that many of the survivors hadn't done any health screen of any kind, even if they had a provider, and were experiencing symptoms. So that was kind of concerning, but we realized that they were prioritizing other needs and putting sort of health as the last thing. So when they came in to get screened, it was sort of a reminder for them. It's like, oh yes, I should go and check my doctor if they had one, or if they didn't, we helped them to navigate that with our community partners, and that seemed to work pretty well. And we got some good feedback from them that actually did go and take those, go to see the doctors to get validated results and then get on a treatment course that was appropriate for them. Of course, there's other social impacts. This was the data coming in from the cohort. More than 70% of the participants reported loss of income after the fires, and that's just the results you can see here. About a third reported job losses and are still looking for employment. There was also significant disparities in the health insurance coverage. So there was, of course, the post-wildfire loss of health insurance coverage overall, but significant ethnic disparities between in the degree of that. And so in the top, you'll see compared to our pre-wildfire cohort, the Maui West, the West Maui average on the bottom is about 5%. So Hawaii does pretty good in general, and this is pretty representative of that on Maui. Was 5% were uninsured, but after the fires, it jumped out to 13%, at least in our cohort. And then how it broke down by ethnic groups, you can clearly see a difference. So Native Hawaiian Pacific Islanders, for example, had twice as many people without health insurance compared to whites, and then it was even worse in the Hispanic and Latino population, where there was more 40% of respondents reported insurance loss, and still actually having struggle with getting the insurance, getting insurance covered. So we are working with organizations like Kaiser Permanente, who have a charitable program, and with our community partners are able to navigate some of these individuals from the study to get, if they're eligible, to get into that program. So at least they can regain some coverage that they lost because of the job, because they don't qualify for other alternatives. And then with, of course, the insurance, loss of insurance coverage, there's also difficulty in accessing medical care. This was up before the fires, fourfold up before the fire. So 4 in 10 people in general in the cohort report having trouble getting medical care and medications, compared to about 1 in 10 that was before the fires from a survey again on Maui. About half of the participants that responded experienced very low or low food security, and this was substantially, again, higher than pre-wildfire survey reports in the cohort on Maui, where it was only less, where at the time it was less than a quarter of participants were found to be food insecure. I mean, that's still pretty concerning. Even before the fires, many were food insecure, but that went up considerably after the fires. On the positive note, it was not all bleak. We did see some elements of resiliency in our community, which was great to see. So these were respondents reporting how they used community organizations and how much they trusted community organizations or other agencies that were coming in, like FEMA. And we found that actually majority of the participants, at least in the cohort, seemed to use and trust more community-based organizations than other government agencies. And it was actually really interesting because that kind of connectedness and resourcing, we saw that those that did had expressed less frequently some of the symptoms that we were actually monitoring and surveying. So that was nice to see. One example of that was actually on the mental health component. So this is some data showing that participants that reported high levels of perceived social support tended to have less depressive symptoms than those reporting low levels of perceived support, who also tended to experience more difficulties accessing care. So if you look at the bottom graph here, the no problems, so individuals had no problems with at least expressing depressive symptoms. Many of them, about 75% of them, expressed high degree of perceived support, social support. But those that expressed depressive symptoms quite frequently, high depressive symptoms there, many of those perceived having medium to low perceived social support. So again, some degree of resiliency and social connectedness and support, and utilization and uptake of community-based programs, which I think actually offers another strategy for us to consider building capacity for responding to disasters like this, and making sure that those community organizations that are trusted and serving in different ways, many of them actually in touches on healthcare, can be accessed and supported more by state and other federal agencies and even academic agencies that can help to promote that in the community. Now, this is preliminary data, and I just wanted to share this because I think it's important to consider these types of studies. We are starting to analyze some samples. It took a while for us to get this done because we were waiting for more funding to come through. These are very expensive technologies. For those of you interested, one of the ways that we can screen, and actually the gold standard approach, to screen for a variety of different exposures, and in particular heavy metal exposures, is this technology called inductively coupled plasma tandem mass spectrometry. And we can use this from urine samples. We send this out to a core facility in Colombia because we have limited capacity to do so locally, unfortunately. But the Department of Health and the EPA have reported specific enrichment of heavy metals of particular agents such as arsenic, lead, antimony, cobalt, and copper in the ash and debris from the fires, right? And that's been an established report. This was taken from sampling of 100 properties in Lahaina in November. And so, you know, we still didn't know exactly the extent of exposures or what that would mean. So we anticipated sending out a subset of samples from our cohort to look at a more of a comprehensive survey of what potential elements might be an issue. So we sent it out to this technology, to use this technology with 33 different elements that we surveyed. 5 of them, I mean, of course, we're including all of the 5 that were already implicated in the ash and debris from the fires. So again, we take the urine samples, process them in our lab, send it out to the core, where they use this technology to analyze, and we integrate this information with the health metrics that we're getting from participants. Because remember, we take spot urine, so these are the urine samples that we take from participants as they go through the study, the stations, and so we have the paired data from all of that at the same time. So this is the preliminary data, again, from a subset of samples, 50 out of the 767 samples that we have that we've actually sent to Columbia University to get surveyed for this. And this is the emerging results. So this is the degree of exposures from the urine samples from that subset, and the density of where that is. So individuals, like for example, you can see arsenic at higher levels here, but it's lower frequency compared to those compared to lower levels of arsenic. But that was the issue for us to see this higher degree of arsenic in the urine. We found the same thing with lead, as well as cobalt and copper, and antimony for some reason it's pervasive across majority of participants. And so we're still looking to understand what this means. The unfortunate thing is that, you know, the standards in terms of the top 6, you know, levels in your sample, in your urine, hasn't really been as well established in our diverse community. It's usually other populations, so those standards are set. So we don't really know how much, whether higher levels, like even these lower levels, actually might impact health. So what we decided to do is just explore the relationship between the levels that we were seeing in the urine compared to some of the emerging health outcomes. And this is what we found for lung health. We did find that copper and arsenic, for example, found in the different levels of arsenic and copper in the urine samples were strongly and negatively correlated with the FEC and FE1 readings, 2 different readings to look at lung health. So the lower that value, the more likely you have a lung obstruction, either mild or severe. And so the high levels of arsenic we can see is associated with this lower levels of the FEC reading, so it seems to be associated with lung function. We also looked at the relationship between the levels of heavy metals in the urine and specific biomarkers from the blood that we've collected on the spot. So again, at the same time, we are seeing this strange phenomenon in this population where there's this higher degree of lactate levels in the blood, and this is resting lactate, so you don't expect that in this particular setting, and we couldn't explain that. But for some reason, arsenic in the urine seems to be positively associated with the higher lactate levels that we see in participants. So it could be explaining some of these issues. We know that from prior studies, other heavy metals like cadmium, for example, can sequester oxygen in the blood and might be contributing to this higher lactate level. So we're still trying to understand how this might affect health. One of the other things that we did was to integrate this with some of the symptoms that were self-reported. What we found, again, for arsenic, which was kind of surprising, was that there was a higher frequency of either eye or skin irritation. So those individuals that came in and complained about the higher frequency of eye or skin irritation, they exhibited the higher levels of arsenic in the urine. So again, linked to a particular outcome. again, not all terrible news. We did see that participants who reported using protective measures after the fires seem to have reduced exposure to lead. And this is the lead levels in the urine sample. So those that self-reported, yes, they used protective measures like mask or purifiers and things like that, tended to have less lead compared to those that said that they did not engage in those protective measures. So we're still looking through and sorting out all the data. Again, it's emerging. We're collecting more information as they come along. But we think that the kind of information that we'll be collecting is a better understanding of some of the impacts from the fires on health outcomes, not only the emerging ones that we see now, but potential long-term impacts. And we're hoping that we can rally a team together to help support interventions on the ground to identify individuals that might be at risk for these health conditions so that we can intervene and reduce potential long-term impacts and higher mortality from the disaster. So some of the recommendations that we explained in our report, I'll share a little bit about that today. Medical care and accessibility seems to be the number one. And it's definitely we need to have a focus on expanding access to care as well as insurance coverage for those that have been impacted. But in particular, in light of these symptoms that we're starting to see, pulmonary, cardiovascular, and mental health support is needed. And what we found, what we've learned from our partners at the World Trade Center, that they've been able to integrate mental health and physical health support in the same facility for their survivors, and they explained to us that seemed to be a much better strategy in order to improve care overall. And so I think that's what we really need to move towards, not just mental health treatment by itself, but also be able to monitor as well as support other health outcomes. So we think that's an emerging need, especially from the data that we're seeing. Of course, housing stability is a major issue and challenge that's still being worked on. Environmental safety, so the results from the exposures and the heavy metals I just mentioned, does raise some red flags in my mind. So that there needs to be more done to encourage best practices and monitoring of some environmental exposures and hazards, and educating our community around some best practices that we know about and some that we see they're engaging in to reduce potential exposures from the recontacts to some of these elements that might still be there after the cleanup. And then of course, what we've learned is working with our community partners was a great strength. And they were able to deploy resources and information readily to communities and individuals that needed it. And so we think that any of these approaches to help with addressing the long-term sort of challenges our community faces, supporting and working with our community partners would be key ingredient in this. And again, like we talked about in other sessions earlier, having a tailored approach to addressing some of these needs is important, because you saw some of the differences in health, the health needs, the insurance needs, and other social needs across different populations from our data. So of course, a cookie cutter approach doesn't really quite cut it, right? So we need to kind of devise one that's from the community as well as for that particular community context and cultural context that we're serving. I think that would play a better role, and we've already heard how that is more effective as a strategy to reduce these conditions. And then finally, I just want to mention again strategies, not just the tailored strategies, but I think going back to the punchline, we were learning that really to build the resilience, and that's what's happening now, where people are envisioning what Lahaina will be right in the future. And hopefully it will be stronger than it was before the fires. But part of that equation will have to be in that community as well as a community across the state, really addressing health disparities, because it's those communities that are much more vulnerable to these types of disasters. And it's just if we don't help to sort of close those gaps, that's just going to widen social inequities, that's going to further exacerbate the health disparities that we see. So I think part of our story for not just in our community in Hawaii, but for the nation, is to consider, when you think about disaster recovery or disaster planning or resilience planning in the community against disasters, addressing health disparities is a critical component and ingredient in that process. So with that, I'll just happy to take any questions. And again, thank you guys for having me here. Mahalo. Any questions?
Jen.
May I know you have a question? Yeah,
This is just
institutional. Is anyone coordinating the type of researchers that are going out there in Maui? Remember back in the day out in Waianae? Yeah, there's so many people from UH and outside.
That would be a good idea.
And using the community folks. And
Right.
I was wondering if there are redundancy in people going out there. So is the Arizona State there? How Arizona State?
Well, I can tell you that there's a lot of, I can tell you working with our partners, there's no coordination, I can say that pretty confidently. There was an effort though to kind of identify resources that the universities have, research resources, core resources, expertise, that could provide some support to the disaster. And there was an effort to catalog that throughout our university system-wide. And I think that's a good exercise because we know who we are and what we can do and maybe get that collective together. But there was no ongoing effort to coordinate any of the emerging research that was happening on Maui. And I do think that that's important because we're also getting interest and we know potential investigators that are interested in coming into our community to do research from the outside, from different parts of the mainland, right? And they are fascinated by what we were able to do, and they want to do something similar, or they want to, piggyback. And I do think that having our community advisory board and our scientific advisory board partners together to help us understand, and to vet some of these considerations about additional research that's done is really important. But that's what we think in our team that we can kind of manage. But there's no sort of larger sort of institutional, kind of coordination of that kind of effort.
So follow-up is, I assume you even have a longitudinal design.
We do, yes.
Right?
Yeah, that's for sure.
And be able to identify whether or not there are other interventions taking place?
Yeah, that was one of the goals, is to identify what are the emerging risk factors and are there appropriate interventions that we can match people to that's resourced already on Maui. And that's one of the questions I was asking with the mental health, because I think that's really fascinating. One of our concerns that the community is expressed is that this is just a cohort of adults, right? And that's where we're able to deploy, but they want to add kids as well, because they're exposed a similar way, but actually even in some senses more vulnerable to the levels of heavy metals, for example, and then of course the longer term impacts, right? So we want to be able to accommodate that request, but of course limited capacity. So we're hoping that we can work with some of the state legislators to help us fund some of these programs to expand it. And we do have we had a bill in the omnibus that would have gone through. The governor vetoed it. Unfortunately, that affected everyone. So we're still trying to manage figuring out how to access resources from the state to help us with the immediate responses, because the research enterprise, a lot of the bread and butter comes from NIH. We all know this, and they take a long time to review, because they're looking at it in a different way. They want the scientific innovation, they want the experts along those lines, not so much like support for the disaster element, the service that we provide, the community support. There's not that much interest in that, unfortunately. And there's not a good mechanism for disaster research from the NIH. There might be some from the NSF, but they don't want to touch human health. So that's another aspect of it that's kind of challenging. So I think if we can get the state to think about programming support and figuring out who are the experts in Hawaii that can help with rallying research teams to address these emerging community needs, match them to interventions that might be appropriate, it's already on the ground, that's being tested or already deployed, that would be really good to do. And we're kind of expecting that with a leader that's in our state that has community ties and a physician himself, they would understand the need and how to do that. So, well, it's too bad I missed him. But I think that having that kind of program support at the state level would be really helpful, because I don't think we can really depend on some of the federal mechanisms right now. I mean, that can be improved for sure. But, my kupuna, like I mentioned, she would say, you don't need to wait. We know what to do. We can do it ourselves. And that's what we did. We just rallied together grassroots, from knowing some of the people in the community and our partners and what we can provide. We just did it ourselves. We went to HCF, and they were actually really enthusiastic. They provided some funding initially. That's how we got started, and I'm just trying to grow that capacity. Yeah, I just hope it doesn't take that kind of Herculean effort every single time a disaster comes around, because it is a huge sacrifice that individuals make, my people on my team, make, but they're dedicated. That's their personal mission as well. So I think you need to have that in place. Anyway, I do think there's still room for us to all learn about how to best handle these types of research. But like I mentioned, I think the highlight for us, and I think I'm really proud of the fact that we're able to leverage research and actually address some community needs immediately. And then as we still learn more about it, the issues, right? And then hopefully be able to respond in a more cohesive and then have a broader impact from the results from the research later. Yeah.
I want to follow up with what exactly because of X that we decided is going to happen.
Mhm.
So,
I think a multidisciplinary, multi-level approach to collect as much data around it, and the periodicity of it is important, doing the longitudinally, and so we can capture some of these effects, and so you can build it into the study design and eliminate and account for these potential observer effects. But I do think, the point I was trying to make was that I think as researchers working in health disparate communities, I think our role should be beyond just collecting and evaluating data and then disseminating that information to community. I think also our role is to be providing some support, education, helping out to change that dynamic in the community in the first place. And I think so in our sort of philosophical perspective as researchers in health disparate communities, right, working with those communities, I think the types of methodology and approaches that we take might be different from those that are looking at sort of more agnostic approaches. But for us, especially in our community, I think that adds value to the work that we do, motivates our students for sure to give back to their community, and that's an angle for them to do research and also kind of get that community tie. And the work that we do is definitely not immediate gratification generally. It's a long road, but I know a lot of our young learners in our community are really passionate about giving back and being able to address some of those needs. That does take a long time to realize, but research is a way to do that, and we're hoping to attract them to that. And I think this approach allows for that to happen because they do engage the community and they actually see the research that they're doing might have an impact, right? Immediate early impact in some cases. They actually were able to do a spirometry reading. Some of my people in my lab, they're focused on microbiome research, but they actually learned spirometry and they were able to at least provide that as a service to the community, right? To learn about people's health. So I think that really, that process, that learning process and incorporating this blended approach really adds value to the training as well as the motivation to provide this kind of support to the community. So there's a lot of elements involved in the kind of research, but I think we can do it in a way that's meaningful to the community, longer lasting, generate interest in the next generation.
On the potential supports for this over.
Yeah, and that's another thing that we there's a lot of changes that happens in Europe, especially from the disaster. So people are leaving and moving and getting re-exposed or having other diets or whatever. I mean, all those things that affect their health in the future as well. It's dynamic. It's playing out. So we have to be aware of trying to connect that information and be able to adjust for some of these differences. And identify whether these exposures are triggering that long-term impacts. And I think it's going to be a little challenging to kind of prove definitively that that's linked. But then in some senses, does it matter? The people are experiencing those problems, right? And we need to just provide them the help. There's no full-time pulmonologist on the island of Maui, yet we have a huge population, especially the survivors, that need specialized pulmonology support, right? And there's this one person that does the half-time, flies in. So there's definitely the access to care and the lack of care, right? And this is just trying to be able to deliver that to meet that need in the community. It's just trying to create the infrastructure and the education, the community involvement around that support. So we do have, like I said, our staff isn't trained and experts in pulmonology support, but we get the experts in to help us calibrate the machines and deliver this information to the community. So technically, actually, we're doing a diagnostic test on the spot. We can't call it that because it's research, but they get that information that they would get in a specialized, pulmonology division. And then they have to get it vetted by those experts that can study this and link it. So I think, while we're doing the research, we can actually affect care, hopefully positively. Yeah, and kind of provide a means for managing some of the acute needs as well as while we're doing the research, trying to identify the long-term issues that might manifest and hopefully reduce and mitigate, some of the outcomes that we might expect.
Maybe one last question?
The Native Hawaiian community that came out to involve themselves in research.
A lot of them in Lahaina were actually right next door. The Hawaiian homestead was right there. And only 2 houses burnt down within the Hawaiian homestead. I knew some of the participants there too. But then the rest, the housing remained intact, but they were affected. Like direct exposures from the smoke, right? And Pacific Islanders. We had a lot of Samoan, Tongan participants in the study. So that's, all together. I think that's also another reason. But we were able to, make sure that that message was not lost because we had members that were affected in our community advisory board helping out to message that. So we could enrich that sampling because we know that these populations are understudied generally. So having more representation would be better, right? And kind of getting an understanding of what the levels of, these toxic levels might mean at the clinical setting in this particular population, which hasn't been established yet. So, I think having that as a baseline is really critical.